Good morning and welcome to the first Orlando Monthly GI Journal Club. My name is Dr. Ji-Young Bang, and today we'll be discussing the most important studies published this month. Now let's begin. Our first study looks at pregnancy and neonatal outcomes after fetal exposure to biologics and thiopurines among women with inflammatory bowel disease. This was published in Gastroenterology. Why is this study important in our clinical practice? The flare of IBD in pregnancy increases the risk of maternal and neonatal adverse events. The safety of thiopurines and biologics in pregnancy is not well established. For instance, animal data show that fetal exposure to supratherapeutic doses of thiopurines is associated with congenital malformations. Biologics are actively transported across the placenta during second and third trimester, and therefore their impact on fetal development is not clear. Also, there have been reported increased maternal complications with anti-TNF therapy. The aim of their study was therefore to compare the outcomes among pregnancies exposed and not exposed to biologics and thiopurines in utero. This was a prospective observational study of 30 US centers with patients enrolled between January 2007 and March 2019. All participants answered a questionnaire at the start of study and then during subsequent trimester, then 4, 9, 12 months after birth, and then the neonatal developmental milestones were also checked at 12, 24, 36, and 48 months. Disease activity for IBD was measured using Harvey-Bradshaw Index for Crohn's disease and simple clinical colitis activity index for ulcerative colitis. Biologics were defined in the study as anti-TNF, anti-integrin, and anti-interleukins. Thiopurines were defined as azathioprine and sexmecaptopurine. The primary outcome measures were congenital malformations, spontaneous abortions, preterm births, low birth weight, and infections. The secondary outcome measures were infant milestones at 12 months following birth. This table looks at the incidence of pregnancy-related complications in 4 different groups: pregnant women not exposed to any biologics or thiopurines, women who are taking biologics only, women taking thiopurines only, and women taking both a combination of biologics and thiopurines. And when these authors compared the rates of pregnancy-related complications in women taking biologics and or thiopurines compared to pregnant women who did not take any medications at all, they found there was no significant difference in terms of any pregnancy complications, spontaneous abortions, the rate of preterm births, low birth weights, intrauterine growth restriction, and congenital malformations. As you can see, these odds ratios all cross 1, and therefore this signals that the risk of developing these pregnancy-related complications in women taking biologics and or thiopurines was not significantly higher compared to women who are not exposed to any of these medications. However, when they looked at factors associated with incidence of spontaneous abortions occurring before 20 weeks, they found that active disease and history of prior spontaneous abortions were significantly associated with spontaneous abortions. For instance, when a pregnant patient had active disease during pregnancy, the risk of developing spontaneous abortion was actually 3.4 times higher than those without active disease, with hazard ratio of 3.4. These authors then looked at the rates of infections in neonates during the first 12 months of life. When they looked at the incidence of serious infections at birth, they found that, again, there was no difference between women who were exposed. There was no difference in women who were taking biologics, thiopurines, or a combination of both when compared to women who did not take any of these medications. When they also looked at the rates of infection, at 4 months of life and in the first year of life. Again, the risk was not greatly increased in babies of women who were taking these medications during pregnancy. As you can see here, the p-values are all 0.27, 0.19, and 0.87, and therefore there was no statistical significance. They also looked at childhood developmental milestones in neonates of these neonates born to pregnant women with IBD, and looked at developmental milestones at 12 months. As you can see, personal and social milestone was actually better in women who had been taking biologics with a mean of 48.6 in unexposed group compared to 52.1 in women who were taking biologics with p-value of 0.01. However, overall, there was no significant difference in childhood developmental milestones at 12 months, whether the women had taken biologics or thiopurines or a combination of both of these medications. The limitations of this study is the self-reported data from questionnaires. There is also lack of objective markers for disease activity in these patients, and there is a possible selection bias due to loss of follow-up. Therefore, in pregnant women with IBD, the use of biologics and thiopurine therapy alone or in combination was not associated with an increase in congenital malformations, spontaneous abortions, preterm births, low birth weight, or infections in the first year of life. Maternal disease activity, however, was associated with spontaneous abortions. Therefore, treatment should be continued throughout pregnancy, given no increase in harm from treatment. Our second study looks at the effects of statin use on the development and progression of non-alcoholic fatty liver disease. And this was a nationwide nested case control study published in the American Journal of Gastroenterology. Non-alcoholic fatty liver disease is one of the most common causes of chronic liver disease. In a patient with non-alcoholic fatty liver disease, it can then progress to non-alcoholic steatohepatitis, which can then progress to liver fibrosis and cirrhosis. Non-alcoholic fatty liver disease, which we'll say is shorten to NAFLD from this point forward, is associated with metabolic syndrome, which includes a combination of obesity, type 2 diabetes, hypertension, and hyperlipidemia. Studies so far investigating the effect of statins on NAFLD patients have shown inconsistent results. So these authors performed a case control study of using the National Health Information Database of the Republic of Korea of patients entered in 2010, and these patients were followed up until 2016. The presence or absence of NAFLD was determined using the fatty liver index. Fatty liver index of less than 30 was determined to be negative for NAFLD, and fatty liver index greater than 60 was determined to be positive for NAFLD. The presence of liver fibrosis was determined using the BARD score. Statin use in this study was defined as usage of at least 30 days. In this study, the authors followed two different groups of people. They looked at patients without underlying NAFLD to begin with, and patients who were known to have NAFLD in the first place. In individuals with no history of NAFLD, the authors followed this group of individuals, and then they looked to see whether statin use affected whether they did or did not develop NAFLD in the future on follow-up. In patients who are known to have NAFLD, the authors followed this group of patients to determine whether they did or did not develop liver fibrosis on follow-up. This table examines the relationship between statin use and development of non-alcoholic fatty liver disease in patients without a known history of non-alcoholic fatty liver disease. As you can see, in patients, in individuals who did use, who has a history of statins, there was a significant reduction in the incidence of non-alcoholic fatty liver disease, with the adjusted odds ratio of 0.44 when comparing those who did and did not develop NAFLD compared. This difference and this reduction in the development of NAFLD in patients who had taken statins persisted whether the patient did or did not have a history of diabetes. When the authors looked at the doses of statins that the individuals were taking, they found that with increasing dose of statin use, that the risk of not developing non-alcoholic fatty liver disease actually the risk of not developing NAFLD actually was greater with the greater dose of statins used. And again, this was the case whether they did or did not use diabetes. So in other words, the more statins you take, lower your risk of developing NAFLD in patients without a history of known NAFLD. These authors then looked at patients who already known to have NAFLD, and then looked at the impact of statin use on the risk of developing fibrosis on follow-up. As you can see, in this group of patients who did have a history of NAFLD, the risk of developing fibrosis on follow-up was significantly lower in patients who were taking statins, and this was the case whether they did or did not have diabetes. Again, higher doses of using statins was associated with lower risk of developing liver fibrosis in these NAFLD patients, whether they did or did not have diabetes. The limitations of this study is that the diagnosis of NAFLD and fibrosis was based on prediction models and not based on histological specimens and radiological imaging. Other interventions related to hypercholesterolemia, such as use of aspirins, fibric acid derivatives, nicotinic acid sequestrants, were not evaluated in this study. Therefore, statin use decreased the risk of NAFLD occurrence in patients without NAFLD, and statin use decreased the risk of progression of NAFLD to liver fibrosis in patients with no NAFLD, regardless of pre-existing diabetes. Our next study looks at intragastric balloon placement on metabolic and histological features in patients with non-alcoholic steatohepatitis. This was published in Clinical Gastroenterology and Hepatology. This was a single-center prospective study evaluating the effect of intragastric balloon placement on metabolic and histological features of NASH in obese patients. These authors identified 21 patients with obesity defined as BMI greater than 30 in patients with known hepatic steatosis or early fibrosis who have failed conservative and lifestyle modifications for weight loss. Intragastric balloons were inserted for a period of 6 months. All patients underwent magnetic resonance elastography, or MRE, prior to balloon insertion, and also EUS-guided liver biopsy at the time of balloon insertion. MRE and liver biopsies were also performed after balloon removal. These are the results. As you can see, following the insertion of intragastric balloon, there was a significant drop in BMI from 43.2 to 37.9 with a p-value of 0.01. They also found that the HbA1c also improved after insertion of the intragastric balloon with a p-value of 0.02. When they looked at the non-alcoholic, when they also looked at the NASH activity score, it also fell from 4 to 1 with a p-value of less than 0.01. Magnetic resonance elastography score was also significantly lower after intragastric balloon placement, and with a score of 3.5 going down to 3.2, and the p-value was 0.03. Therefore, intragastric balloon placement resulted in significant metabolic and histological improvement in patients with NASH. Our next study looks at the life expectancy after bariatric surgery in the Swedish obese subjects. This was published by Carlson et al. In the New England Journal of Medicine. Obesity is associated with reduction in life expectancy and significant comorbidities. Bariatric surgery has been associated with a decrease in mortality. However, long-term effect on survival is unclear. The aim of this study was therefore to compare mortality rates and life expectancy in obese patients undergoing bariatric surgery versus obese patients undergoing only lifestyle modifications versus the general population. These authors used a database from 25 surgical departments and 480 primary healthcare centers in Sweden. Patients were enrolled from 1987 to 2001. Obese patients were defined as BMI of greater than 34 for men, 38 for women, and patients aged 37 to 60 years were enrolled. Individuals were then divided into 3 groups. Number 1, it consisted of obese patients who underwent bariatric surgery, which included vertical banded gastroplasty, gastric banding, and gastric bypass. Second group consists of obese patients who underwent lifestyle modifications only, without surgery. And then these groups were compared with a random sample of patients from the Swedish population registry, matched for age, so aged 37 to 60 years. Follow-up was performed in December 2018. When the authors looked at the change in BMI in patients who underwent bariatric surgery, the mean reduction in BMI at 1 year post-surgery was 11. Then they noticed that the weight increased gradually until about year 8 after surgery, and then it plateaued to a baseline of about 7 less than the BMI, than the baseline BMI prior to surgery. Then these authors looked at mortality and life expectancy in the 3 different groups: obese patients who had surgery versus obese patients who only went lifestyle modifications, which is titled as control group in the table, and then the reference cohort of patients chosen from the general population registry. As you can see, first looks at mortality rate, and they looked at the hazard ratio, which basically is the risk of death. The control group they used to compare the hazard ratios between the 3 groups is the control group. These are, remember, obese patients who underwent only lifestyle modifications. So if you look at obese patients who had surgery, the risk of death is actually significantly lower compared to obese patients who had lifestyle modifications only, with hazard ratio of 0.7 and p-value less than 0.01. But if you look at the risk of death in the general population, the risk of death in the surgery group is still, even though risk of death is less than compared to the lifestyle modification group, is actually still higher than the general population. Then they looked at life expectancy. When you look at the surgery group, i.e. obese patients who had bariatric surgery, the median life expectancy is 3 years longer than obese patients who only had lifestyle modifications. But the life expectancy in the surgery group is still 5.5 years less than the general population. Therefore, in obese patients, bariatric surgery was associated with longer life expectancy than lifestyle modifications. However, regardless of the treatment approach, risk of mortality was greater in obese patients compared to the general population. Our final study looks at prognostic relevance of circulating tumor cells in blood and disseminate tumor cells in bone marrow in patients cohort with esophageal cancer. This is published in Annals of Surgery. Esophageal cancer is the 6th highest cause of cancer-related deaths, with poor prognosis. Cancer recurrence and occurrence of distant metastases remain significant issues following treatment for esophageal cancer, including after complete resection with tumor-free margins. The role of disseminated tumor cells, which is found in bone marrow, and circulating tumor cells, which is found in peripheral blood, in the prognosis and survival in patients with esophageal cancer warrants further examination. This is a prospective study performed in a single tertiary center at the University of Hamburg. These authors took 64 patients with esophageal cancer, but without distant metastases. 64 patients underwent esophagectomy, but without neoadjuvant treatment. Immediately prior to surgery, bone marrow aspiration was performed from the upper iliac crest to look for disseminated tumor cells. And peripheral blood samples were collected for circulating tumor cell analysis. Follow-up was performed every 3 months for a minimum of 2 years or until death. The aim of this study was to evaluate the impact of disseminated and circulating tumor cells on patient survival in patients undergoing esophagectomy for esophageal cancer. Disseminated tumor cells were found in 13% of patients. Circulating tumor cells were found in 16% of patients, and both disseminated and circulating tumor cells were found in 4% of patients. Then these authors looked at the overall survival in patients who did and did not have circulating tumor cells, and patients who did and did not have disseminated tumor cells. The survival curve, as you can see, is known as the Kaplan-Meier survival curve. It essentially plots patients still alive over a follow-up period, which is displayed in the x-axis here, which is the time here in months. The opaque line here, the black line here, are patients who did not have circulating tumor cells. The dotted line here represents survival in patients who did have circulating tumor cells. As you can see, survival is lower in this dotted line, who are patients with circulating tumor cells. And this difference in survival was significant with p-value of 0.038. In comparison, if you look at patients who did and did not have disseminated tumor cells, as you can see here, the dotted line represents patients who did have disseminated tumor cells compared to those who didn't. Survival appears lower in those patients who did have disseminated tumor cells. However, this difference was not significant with p-value of just 0.455. Then they looked specifically at recurrence-free survival. And again, the same pattern is seen as with the overall survival rate. So in patients who did have a positive circulating tumor cells, the survival is significantly lower than those who didn't. However, the presence of disseminated tumor cells did not significantly impact relapse-free survival. These authors then also performed a multivariate analysis to look at factors associated with overall survival and relapse survival. And as you can see, the factors associated with, significantly associated with survival is having negative circulating tumor cells and basically having lower tumor stage. A different way of expressing the same meaning is that if you look at the risk of death, having a positive circulating tumor cells and higher tumor stage 3 versus 1, was significantly associated with increased risk of death, both in terms of overall survival and relapse-free survival. Therefore, the presence of circulating tumor cells was associated with shorter survival in esophageal cancer patients undergoing esophagectomy. The use of circulating tumor cells to improve risk stratification in patients with esophageal cancer appears promising. So in a quick recap, in pregnant women with IBD, treatment should be continued given there is no increase in harm from treatment. Statin use decreased the risk of NAFLD occurrence in patients without NAFLD and decreased the risk of progression of NAFLD to liver fibrosis, regardless of pre-existing diabetes. Placement of intragastric balloons resulted in significant metabolic and histological improvements in patients with NASH. In obese patients, bariatric surgery was associated with longer life expectancy than lifestyle modifications alone. However, regardless of the treatment approach in these obese patients, risk of mortality was greater compared to the general population. The presence of circulating tumor cells was associated with shorter survival in esophageal cancer patients undergoing esophagectomy. Thank you very much for joining us. Our next Orlando Monthly GI Journal Club will take place on March 3rd, 2021 at 0700 hours Eastern Standard Time. Thank you very much again and look forward to seeing you soon. Thank you. Bye.